Chapter 12, Schizophrenia Spectrum Disorders. So these disorders share features with schizophrenia, which is characterized by psychosis, a disconnection with reality caused by disturbances in a client's thoughts and perceptions, that is also characterized by hallucinations, troubling thoughts and beliefs, emotional changes, withdrawal, and lack of self-care. We will first discuss some disorders that fall on this spectrum, and then we will discuss schizophrenia in detail. So first we have delusional disorder. These are false thoughts or beliefs that have lasted for at least 1 month, but not severe enough to impair functioning. Delusions can be grandiose, so large and extravagant, persecutory, which is relating to persecution, somatic, which are feelings of abnormality, internally or externally, or referential, which are normal events and behaviors that have hidden meanings. Then there is brief psychotic disorder. This is a sudden onset of at least one of the following: delusions, hallucinations, disorganized speech, which are incoherent or say things that are off topic, or disorganized behavior. This behavior must last longer than 1 day, but must be less than 1 month, and these people will likely return to normal functioning. Schizophreniform disorder. It is the same symptoms as schizophrenia, but it has lasted less than 6 months, and they have impaired social, occupational functioning, may actually not be present. So they may not have impaired social, occupational functioning. Schizoaffective disorder. This is characterized by major depression, manic or mixed episodes, as well as all the other symptoms related to schizophrenia. Symptoms cannot be caused by any medication or substance. And then substance-induced or caused by medical condition. It must be caused by illicit drugs, alcohol, medications, or toxins, or a medical condition such as delirium, neurobiological disease, hepatic disease, renal disease, etc. So schizophrenia affects about 1% of the population, and it is characterized by psychosis. Now there is a stigma that leads to limited healthcare access, underdiagnosis, and undertreatment. Child onset, which is before the age of 15, and late onset after the age of 40 are rare. Most people with schizophrenia can lead productive lives when treatment and support are available. They are 14 times more likely to be victims of crime or violence than the greater population. And half of those diagnosed with schizophrenia have a co-occurring mental health disorder. So for DSM-5 criteria, 2 or more symptoms must be present for 1 month or longer, with signs of continuous disturbances for at least 6 months. These include delusions, hallucinations, disorganized speech, gross disorganization, and negative symptoms, which are diminished emotional expressions or avolition. They must also have functional impairments such as self-care, work, or interpersonal relationships must also be present. Other disorders and substance use should be ruled out before diagnosing, and you can see the criteria box on page 191. So epidemiology. Schizophrenia is typically diagnosed when a client is between the ages of 16 and 30 years old. It is more prevalent and it does appear earlier in males, and there is no difference related to race or culture. Comorbidities. You commonly see substance use disorders, especially alcohol and marijuana, anxiety disorders, and they use nicotine to cope, depression, suicide, physical illness, and polydipsia, which is a compulsive drinking of fluids. Risk factors, biological factors, there's about an 80% genetic related risk. neurobiological, neurotransmitter involvement, especially dopamine receptors, brain structure abnormality. They tend to have atrophy and neurodevelopmental errors or inflammation that can be the causes. CT, MRI, functional MRI, and PET scans can be performed. And you can see your bullet points on page 192 to dig deeper into that. Prenatal stressors, infection during or after pregnancy, as well as the father being older than 35. Environmental factors, social, psychological, and physical stressors, toxins found in the environment, psychological factors such as childhood sexual abuse or trauma or factors. And then there's prognostic variables. These are residual symptoms that remain due to lack of complete response to a medication or treatment. So there are phases to schizophrenia. The first phase is the prodromal phase. There are nonspecific symptoms such as lack of motivation, social isolation, and difficulty concentrating. It is difficult to diagnose schizophrenia in this phase, but symptoms typically start 1 to 12 months before the first full episode. Acute phase, they will have noticeable symptoms that can be mild to disabling. Functional impairment occurs during this phase and can last for several months. Support, treatment, and hospitalization may be required. Next is the stabilization phase. Symptoms begin to stabilize and the patient moves toward recovery and a new level of functioning. This phase can last for months. And finally, you have the maintenance or the residual phase. The patient develops a new baseline and positive symptoms have been significantly diminished. Negative symptoms can still be present, and cycles of relapse are common. So during the prodromal phase, early assessment, diagnosis, and treatment is crucial. You can refer to box 12.1 on page 194. Can schizophrenia be prevented? But from a general assessment standpoint, figure 12.2 on page 195. Give you the four main groups of your general assessment. So you have what's known as positive symptoms. These are symptoms that should not be present, such as hallucinations, delusions, and disorganized speech. Then you have negative symptoms, which you've heard me refer to before. This is the absence of qualities found in most people, such as facial expressions and emotional response. They may suffer from anhedonia, which is the inability to enjoy activities, and avolition, which is a lack of motivation. Then they may have cognitive symptoms. These are difficulties with concentrating or thinking clearly. They can be subtle or they can be very obvious. And then there's affective symptoms, and these are symptoms that involve emotions, such as dysphoria, suicidality, and hopelessness. I would be familiar with this figure. So let's talk a little bit more about positive symptoms. Positive symptoms are usually the reason people seek treatment. There is an alteration in their reality. They have delusions and they have an inability to think abstractly. And they will have alterations in speech. So let's talk through these definitions here, and you need to be familiar with them. They will have associative looseness. This is poor concentration and loose connection of thoughts. They have something called word salad. These patients have ideas that do not connect to one another, and their speech is illogical and it is garbled. Clang association. These are usually rhyming words that are chosen based on their sound rather than their meaning. Neologisms are words that do not have a defined meaning. Echolalia is repetition of words from another person. Circumstantiality. These are long conversations with many unnecessary and unrelated details. Tangentiality, this is going off on tangents and never getting around to the actual point. Cognitive retardation is a slowed thinking. Pressured speech is intense, continuous speech without allowing others to speak. A flight of ideas is rapid movement from one thought to another. And symbolic speech, this is when they say what is a symbolism and not the actual meaning of the word or phrase. You can find these definitions on pages 195 and 196. So they also have disordered distortion of thoughts, and they have something called thought blocking. I was trying to, there it is. Thought blocking is the interruption of thought, and it's often caused by hallucinations. They can also have thought insertion, which is believing that someone has inserted thoughts into their brain. Thought deletion is believing that thoughts have been taken or deleted. And magical thinking, believing that thinking something can change an outcome. And paranoia, this is irrational fear that can range to mild to very intense, and safety measures may be required during paranoia. But these patients can also have alterations in perceptions. They may have hallucinations. They are experiencing something that is not actually there. These hallucinations can be auditory, visual, olfactory, gustatory, tactile, or command. Command involves a person hearing a command, and that can be dangerous, such as jump out of the window, or it can be visual. If it's visual, it is helpful to ask the patient what is being seen. Keep the patient as calm as possible while helping the patient feel heard and understood. Asking about what is being seen is a direct question, without arguing about what the patient is or is not seeing, which can promote a calm and safe interchange and help them feel understood. There is also illusion, which is a perception that is misinterpreted. An example is hearing the wind as someone crying. And then there's depersonalization. This is the feeling of being detached from one's body, or that body parts do not belong or are different in some way. And then derealization is feeling alienated or detached from their surroundings. Now, with the positive symptoms, you will see alterations in their behavior, and these alterations involve changes in movement or behavior that is inappropriate. They may have catatonia, which is under or overactivity in movement, with the most common being underactivity with no movement at all. Catalepsy is muscle rigidity, and it can occur in which the limbs remain in whatever position they are placed in. You can see the picture on the slide for that. Motor retardation is pronounced slow movement. Motor agitation is pronounced excited behavior such as pacing. Stereotype behaviors are repetitive, purposeless behaviors. Echopraxia is mimicking another person's movements. Negativism is resisting another person's request. Impaired impulse control is the inability to control impulses and can increase the risk of assault. Gesturing or posturing are unusual expressions, posturings, or positions. And boundary impairment is the inability to see where one's boundary ends and another person's boundary begins. Next, we will move into negative symptoms. These are the absence of essential human qualities, and they're more difficult to treat than the positive symptoms. The first one is anhedonia, which is the inability to experience pleasure. Avolition, which is reduced motivation. Asociality, which is social withdrawal. Apathy is decreased interest in activities. Alogia is reduction in speech. Affect is the outward expression of a person's emotions, and it can be described in the following ways. Flat, which is just being blank. When you look at them, they're just blank. Blunted, it's just this minimal affect on their face. Constricted is less intense. Inappropriate, it does not pair with the situation, so maybe they're laughing outrageously and someone just died. And then bizarre is odd, it's illogical. Blunted and bizarre are both negative symptoms. You need to know the difference in your negative and your positive symptoms. Now, cognitive symptoms can be things like concrete thinking, which is responding in a literal manner and not thinking abstractly. Impaired memory, it usually affects the short-term memory. Impaired information processing, which are stimulations in environment that can lead to delayed responses or misperceptions. Impaired executive functioning, interferes with problem solving and includes difficulty reasoning or planning. And anosognosia is the inability to recognize one's illness due to the actual illness itself. This, along with paranoia, usually results in resistance to treatment. Affective symptoms include an altered experience and expression of emotions. Assessment for depression is crucial because it may herald an impending relapse. It increases substance abuse, increases suicide risk, and it further impairs functioning. So the nursing process. Assessment, it'll be like we discussed previously, it is important to rule out a medical condition or a substance use disorder. Perform a mental status exam that includes cognitive assessment, self-assessment. So nurses should recognize anxiety, fear, frustration, and unrealistic expectations. And when you're questioning these patients, limit the number of questions asked, especially if they are in an acute schizophrenic episode. Your nursing diagnoses can be found on table 12.2 on page 199 for various examples. Outcome identification. So there's these phases. Phase 1 is the acute phase. So we need to ensure patient safety and medical stabilization. Phase 2 is stabilization phase. So we need to help the patient understand their illness and treatment. We stabilize their medications, and we can help them control or cope with their symptoms. And phase 3 is the maintenance phase. Maintenance and prevention relapses are key here. We help them achieve independence and a satisfactory quality of life. So planning focuses on how to ensure patient safety, control symptoms, and prevent relapse. So implementation during the acute phase, thorough evaluation is needed that incorporates psychopharmacological treatment, support, and guidance. Supervision and limit setting are important in this phase. Now, aggression can happen, so continue to monitor risk and take safety precautions, which you can find on page 200 to 202 under table 12.3. Now, stabilization and maintenance phase, we need to assure medication adherence, help them develop therapeutic relationships with providers, and attend activities and groups. The National Alliance on Mental Illness and Best Practices in Schizophrenia Treatment Center are great resources for information. Counseling and communication techniques. The purpose is to build a trusting relationship. So when they're having hallucinations, understand the patient's experiences and responses. Delusions, never try to prove that the delusion is incorrect because this is reality to the patient. Trying to prove them wrong can lead to mistrust of staff. And while they're having delusions, the patient could experience something called ideas of reference. This is where the patient believes all events, situations, or interactions are directly related to them. They could also develop associative looseness, which is overstimulation. Overstimulation will worsen associative looseness. And then help teaching and promotion. Caregivers and significant others should be included in teaching. We need to identify causes and risk factors as well as medication treatment and side effects. All of this is very important. Evaluation. We need to reevaluate progress regularly and adjust treatment when needed. Even after symptoms improve outwardly, inside the patient is still recovering. So set small goals because recovery can take months. And active, ongoing communication and caring is essential. Treatment modalities. Antipsychotic medications, both first, second, and third generation, are options for treatment. And we'll go into more detail about each one over the next several slides. But antipsychotic medications provide symptom control and allow most patients diagnosed with schizophrenia to live and be treated in the community. Now, it will usually take anywhere from 2 to 6 weeks to see results, and monotherapy is recommended, so one drug. These medications are not addictive, but the patient should wean off of them to eliminate discontinuation syndromes. And then there are injectable antipsychotics. These are used in emergency situations if the patient becomes agitated and or aggressive. They can also be used if the patient refuses court-mandated oral medications. Now, injectables can be short or long-acting, with long-acting only being administered every 2 to 4 weeks, and that can help reduce non-compliance. You can find more information on page 212